Hi, I'm Dr. Carrie Colen. I'm a board-certified plastic surgeon. Most of the work that I do is in northern New Jersey out of Hackensack Hospital. Oftentimes, after somebody's had a lumpectomy or mastectomy, the nerves to the breast and the skin are cut because they travel through the breast tissues. When we do a mastectomy, we're removing the breast tissue. We're leaving behind some of the skin or all of the skin, but we're removing the breast tissue. And the nerves that travel and to the breast are cut during that process. So when nerves are cut, different things can happen because they will grow back. They could grow back and you feel fine. They could grow back and you really don't feel very much different. You're still relatively numb and they don't really do anything. Or they could grow back, causing pain as they grow back because they're growing back in a strange way, or your brain is interpreting the signals that they're sending in a way that makes you feel like you're having pain. And I think when that happens, we call that post-mastectomy pain syndrome. Symptoms can be very broad. A lot of people describe burning, shooting. They describe it as zips or zingers. The patients will describe it in many different ways. A lot of people will jump at very specific tenderness points where they'll feel like a zip or a zing that travels through their chest. And that's usually the most common things that we hear. Some people will describe sensory issues though. So when you touch them, they feel very raw or very sensitive to just light touch. Some people will describe a burning sensation. So it's very different because the brain interprets signals for everybody a little bit differently. So there's no definitive test that you can do to define it or to tell somebody that this is something they definitely have. You do a physical exam, which is number 1, 2, and 3 at how you diagnose it. You take a really good history, you talk to somebody and you ask them how they're feeling and you go through all of everything in their history. And then in the office, it's very easy to inject the areas of specific pain with a numbing medicine. And if that elicits relief, then we have a good idea that a nerve is involved in the pain that they're experiencing. We also have pain management colleagues that can help us with the diagnosis. So we'll refer to them to have them evaluate the patients as well and help define the pain that they're feeling a little bit better. I think the first important conservative treatment is physical therapy. So I think it's really important to start physical therapy early. And that includes not just moving around, but also scar release and desensitization therapy. So you really want the signals that your brain is getting to be good signals, not bad signals. And a physical therapist can help you interpret the signals that you're feeling in a good way as opposed to a bad way. So I think that's the first step. And then that would be the non-invasive therapy. Then you have the middle of the road, which would be a pain management doctor who would do injections, which is slightly invasive, but not as invasive as surgery. And they might be able to inject the nerve with certain medicines that help either dissolve the problem and if that doesn't work, then you have to go to a more invasive modality, which would be surgery. I think surgery is correct when you've exhausted non-surgical treatments. So you've done your physical therapy, it's not working. And you've really done it. Like you haven't just gone once or twice and it didn't work. You've really done a 3-month course of physical therapy and it didn't work. You are cancer-free in the area. So we do want to make sure that it's not like there's a work area. So we would get imaging studies or work with your cancer doctor to make sure that they felt that that wasn't the problem. And you've seen a pain management doctor and they've exhausted their modalities where it's really something you're not interested in doing because not everybody wants the injections. And then I think it's also important for the physician who's going to do the surgery to be able to go after a target. So on a physical exam, you really have to be able to have a specific place that you want to go after. And I think that's when somebody's ready for surgery and they're willing to accept that the risk that it might not work. It's an outpatient surgery, so you come in and go home the same day. It is a small incision, so you do get a scar or an additional, we can either use the scar you currently have if it's in the right place, or we have to extend or add a scar to your chest wall. Again, you come in, you go to the operating room, you go to sleep. We have to make a small scar on your lateral chest wall. Then the surgery takes about an hour to an hour and a half to do. You wake up, you go to recovery room, and you go home. So it's an outpatient surgery that's relatively straightforward with minimal recovery. So I think ideally after surgery, patients should have significant decrease in pain or no pain at all. That's the ideal desire for both the doctor and the patient. It's not always completely gone. So I think that any mitigation in symptoms is a win for everybody. But ideally, in my hands, I tell patients that they should feel at least a 60% relief if I'm able to find something during the operation. So I think that I don't think it's unreasonable to tell patients that they should be at least 50% better if the surgery is done and you find a nerve that is causing the problem.